Good evening, all. Welcome to Remedy International academic programs. We all know that Remedy International is doing regular programs to improve our and also fine tune our knowledge. So we have noticed that many of emergency physicians, your ICU doctors, when there is a need of supraglottic airway devices is there, they are not using or not willing to use because of the familiarity of the devices. So then I decided to have one discussion on supraglottic airway devices in emergency airways. So to discuss this part, we have Dr. Chetan Bhatt, intensivist from Mysore, and also Dr. Prashant Kumar K, anesthesiologist and critical care specialist. So I will request Dr. Prashant and Dr. Chetan to give overall idea about use of the supraglottic airway devices, especially in emergency areas, in emergency department, critical care areas. They can better use these devices to we can avoid hypoxia and hypoxia related complications. Okay, well, over to Dr. Prashant Kumar.
Thank you, Dr. Raghunath, and good evening, everybody, and welcome to this session. The topic for today is supraglottic airway devices in emergency. Okay, it can be used, supraglottic airway devices, mainly LMA, can be used as a rescue device. It doesn't need so much of specialization as you require for an endotracheal intubation, and it is very easy, and everybody can be trained easily. So that is one of the advantages of this supraglottic airway. So today Dr. Chetan will be going in detail about the types of supraglottic airways, the uses, what are the advantages, and what are the classifications. He will be dealing everything in detail. So let me introduce about Dr. Chetan. Dr. Chetan did his MBBS from Ramaya Medical College, Bangalore. Did his MD in anesthesiology from WIMS Ballari. He has special interest in critical care and pain medicine. So I would request Dr. Chetan to kindly continue and enlighten us about the advantages and what are the practical points, how it is better or what way we can use it in a better way in ICU. Please, Dr. Chetan.
Yeah, good evening, everybody. I thank Dr. Raghunath and Dr. Prashant and Remedy International for providing this opportunity. Today's topic I will be covering about the supraglottic airway devices in emergency airway. I presume the understanding is from the basic. I will be going to a little bit complex. So introduction and users and how to use or when not to use, those topics will be covered. So coming to the next slide. So today I will be discussing about the introduction, types, advantages, functional roles, contraindication, insertion techniques, LMA maintenance, LMA removal, and finally where the supraglottic airway device or LMA actually fits into the airway algorithm when we are dealing with any airway emergencies for that matter. So LMA was one of the recent inventions in around 1983 by Archie Brain. Before that, for us, the airway management was introduction of endotracheal tube or tracheostomy. These were the two devices, mainly used devices for airway control. So what the Archie Brain and from UK did was, he tried to use the supraglottic airway to manage the airway. So this invention helped us, this device helped us to avoid intubation for a certain point of time. So LMA device is mainly used as a temporary method to maintain an open airway. And because it is lying above the glottic, it can be used immediately as a life-saving measure in both elective and difficult and failed airway measures. So mainly it was earlier used in anesthesia where the duration of surgery was shorter duration. Then gradually it over years, we have found it useful in emergency also. So settings include OT, ICU, emergency room, and out of hospital settings also where you need not have a laryngoscopy to maintain an airway. And in BLS and ACLS, it is more effective than bag and mask ventilation for rescue breaths because we are maintaining an open airway and the risk of aspiration is lesser than bag and mask ventilation. And also it can be used as an alternative to intubation and also for the facilitate endotracheal tube insertion in a difficult airway algorithm. Coming to parts of an LMA, how it looks, it is a tube where the one end of the tube can be connected to the standard airway connector, where we can connect to the Bain circuit or ventilator circuit. So this is the airway tube which has a conduit for passage of the air. And at the end of the tube, this is the cuff, which is designed so that it sits on the laryngeal inlet, covering the laryngeal inlet, and the tip of the cuff lies on the esophageal inlet. So what the device does is it seals the lower part of the pharynx where the laryngeal and esophageal inlet opens and diverts into esophagus and trachea. So this was an invention which helped us without visualizing the airway. We can blindly insert and make use of the invention where we can protect the airway for some amount of time and also for maintaining airway. So the idea of LMA is to block or obstruct the esophageal opening with its tip. So with its tip, it is blocking the esophageal opening. And then it seals the laryngeal inlet with its cuff. And because the airway, the oral cavity also has a bigger organ tongue, which it normally obstructs, and along with that epiglottis also, it elevates or moves away the tongue and the epiglottis away from maintaining the airway. So by using these three physiological structures, this LMA secures the airway and provide conduit for passing endotracheal tube and gastric tube also. How it provides an conduit for airway through the main air tube. And because this seals the esophageal tube, there is an opening in second generation LMS, which we'll discuss later. It provides a conduit for gastric inlet also, esophageal inlet. So there are various models available because once the Archie Brain discovered classic LMA, there was gradual improvisation, gradual needs were met by the different modification by different manufacturers. The first generation included the classic LMA, which he had invented. And based on that, this is the classic LMA, where there was no port, gastric port. So gradually he invented and improvised on the classic LMA and brought out Procil LMA, Archie Brain, in around 1989-90, around that year. So introduction of gastric port made the generation shift to second generation LMS. Most of the available LMS are either first generation or second generation. There is no third generation as such. And it is available on various sizes. So size the 1 to 6. For pediatric neonates, we start with 1, then 1.5, 2, 2.5, 3, 4, 5, 6. Based on the body weight, we use the sizes, various sizes. So for normal Indian adult, female, we use generally 3. That is, we have assumed the weight of the patient is around 30 to 50 or 4, or around 50 to 70. Size 4 LMA is generally used. So these are the various types. Most common types which you find in hospital settings is IGEL LMA and classic LMA. These are the two important types which we need to aware. And the other types include laryngeal tube, then secure classic LMA, then there is fast track LMA, then also there is Ambu company's LMA, Supreme LMA. So these are the various terminologies. Various companies have produced their own terms. But basically it is a supraglottic device which sits on the laryngeal inlet. So what are the advantages of LMA? How it helps us? The advantages include it is relatively easy to learn the skill of insertion and maintenance. So it is the skill set available to insert an LMA is at a lesser degree to compared to the intubation. And depth of sedation required is less while intubating LMA. So you need not use muscle relaxant while inserting an LMA. And minimal neck movements during insertion is also possible for successful insertion of LMA. So these are some of the advantages. Then compared to bag and mask ventilation, the LMA risk, aspiration risk is relatively less, because with the passage of gastric tube, we can decompress the gastric contents. And in difficult airway, we can mitigate do not oxygenate and do not ventilate scenario. This I will discuss at the later point of the slide. So these are some of the advantages of LMA per se. And LMA role in ACLS, adult CPR. It includes no need to visualize the glottic opening and can avoid the laryngoscopy. So this saves some time. This lessens the time of CPR interruptions. And there is no need to interrupt chest impression during insertion of LMA. So this is one of the advantages of LMA. And functional roles, where all we can use this. It can be used in pre-hospital settings and during CPR, during difficult anatomical airway scenarios, and during difficult physiological airway scenarios. There is a difference between physiological difficult airway and difficult anatomical airway. So difficult physiological airway include where we can use in situations where the depth of anesthesia or depth of sedation required is little bit lesser. So we can avoid hemodynamic compromise. In those scenarios, we can use the LMS. And we can also use LMA as a bridge to endotracheal or fiber optic airway insertion, as a bridge to extubation in during weaning time. When the patient is not able to fully tolerate the endotracheal tube, we can switch over to LMA and try for extubation with LMA. And as a bridge to tracheostomy for the front of neck access, we can also use LMA instead of endotracheal intubation. So some of the other functional roles of LMA includes as a conduit for passage of endotracheal tube. We have commercial product like fast track LMA and intubating LMA. And another thing which I have already discussed. So what are the contraindications for LMA? So basically, insertion of LMA is a clinical decision. There is no absolute contraindications. So based on the emerging clinical scenario, how the patient is, mainly we can relate the contraindications are there. Some of the major contraindications obviously include oral and pharyngeal pathology, where placement of LMA is difficult. Increased risk of full stomach or pulmonary aspiration, that is also a relative contraindication where we can avoid LMA. And because the laryngeal seal requires lesser pressure, the lung compliance, reduction of lung compliance helps, or in the sense will not help in the LMA insertion and maintenance. What I mean to say is, because of the reduced lung compliance, the LMA will not be able to adequately ventilate. So in those scenarios, we need to avoid LMS. And where there is a surgical pathway of the larynx or the oral cavity, obviously we can't use LMS, where the endotracheal tube is preferred. So there is a mnemonic to predict difficulty in insertion of LMA. We call it by Rod's mnemonic, where it is difficult in these scenarios. It is predicted that it is difficult to insert an LMA. Restricted mouth opening. We can't easily glide the LMA inside the oral cavity. Then obstruction or obesity, where there is a tumor or foreign body in the oral cavity, where there is an obstruction to passage of the LMA. There it is difficult to insert. Obesity. In obesity, the pharyngeal mass, pharyngeal tissues will be pressing on the LMA, where the leak may present. So in those cases, it is difficult to insert an LMA. And disrupted or distorted anatomy. Then short thyromental distance. Short thyromental distance is from the placing the three fingers in below the thyromental distance mentals to the thyroid cartilage. So if this is less, obviously it implies that there is a small mandibular distance where the tongue lies. So the cavity for the tongue, the space for tongue is less. So in these cases, it is difficult to insert an LMA. So these are some of the difficult predictors for LMA insertion. Then before going for LMA insertion, we always need to have certain checklists. One is to have an airway plan. If this fails, what next? So plan A, plan B, we need to have airway plan. Then checklist before completion of insertion. So we need to have working suction, working laryngoscope, alternative airway, positioning, drugs, IV cannula, all those things has to be completed before insertion. In elective, in emergency, we need to modify suitably the checklist. Then patient positioning, we can use sniffing position or lateral can also be used. And the next step is to clear and suction the oral cavity. So it is the secretions of the oral cavity is minimized. Then we need to select the size. We need to have two sizes for a particular patient so that if one size is not properly fitting, we can have the second size as a second backup. Then because most of the LMAs in our scenarios are reused after sterilization, we need to see whether the LMA has suffered any wear and tear. So visual inspection of LMA is also required. So the technique includes, I'll be showing video in the next or coming slides, is to hold it like a pen. The posterior cuff is facing the nose and the cuff is towards the front of the, facing the face of the patient. So we holding it like a pen with the thumb and index and pressing, opening the mouth and little bit extension if the neck permits. In trauma cases, we need to have cervical stabilization. In those cases, we avoid this maneuver. Otherwise, jaw thrust can be done. Though in that we are pressing the LMA against a hard pellet and in a single smooth motion, we will be inserting till there is a resistance to further movement. Once there is a resistance to further movement, we'll be inflating the cuff. The volume of air that is required for LMA sealing depends on the size. Generally, it is mentioned on the LMA itself, how much cuff air is required. So for size 3, it is around 20 and size 4, it is 30 ml. So based on that, plus or minus, based on how the effective seal is, you can easily seal the LMA cuff. So this is one of the videos. Just a second.
Using the airway, make sure
So
the
this is
mask
a
fits
Supreme
properly.
LMA.
Before inserting the laryngeal mask airway, deflate the cuff completely, making sure there are
In
no
this, they are
folds or
checking
bumps in the
the
mask.
cuff.
Lubricate the posterior surface of the mask with a water-soluble lubricant. Place the laryngeal mask airway in the open mouth with the
See
opening of the
how
mask
she is
facing
holding the
patient's
LML in the
tongue.
pen like.
Advance the device to the back of the tongue.
So
In
she
a
is pressing
smooth
against the
motion,
hard
use your
palate.
index finger to press the laryngeal mask airway against the roof of the mouth and downward. Continue
So
advancing
here
the
it's
device
sealing
until
against
you
the
feel
esophageal
resistance,
opening.
which indicates the distal end of the tube has reached the hypopharynx. Withdraw your finger and inflate the mask. A size 4 mask will take 30 milliliters of air. A size 5 will require 40 milliliters. Once inflated, the laryngeal mask airway will center itself in the
So
mouth.
here it is sealing the
If placed
esophagus.
correctly, oxygen will flow from the device into
And
the
through
trachea.
this, there is a airway conduit.
Using the
This is another video where we are using ProSeal, where the demonstrator is using a ProSeal LMA. ProSeal LMA doesn't have a cuff. It is, not ProSeal, iGel LMA. It doesn't have a cuff. It is made up of gel-like gelatinous material where
The back, sides, and front of the cuff with a thin layer of lubricant. Ensure any excess is removed. Grasp the lubricated iGel O2 firmly along the integral bite block. The ideal patient position for insertion is with the head extended and the neck flexed. But if this is not possible or is inappropriate for the patient, then iGel O2 can be inserted with the head in a neutral orientation. A proficient user can achieve insertion of iGel O2 in less than 5 seconds.
So this is the time that is required.
Introduce the
Ideally,
leading
you
soft
can
tip
insert it
into the mouth of the patient
with
in a
less than
direction
5
towards
seconds.
the hard palate. It is not necessary to insert fingers into the patient's mouth. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force.
So till
The tip of the
definite
airway
resistance
should
is
be
there,
back, sides, and front of the cuff with a thin layer of lubricant. Ensure continuous but gentle felt. Do not apply excessive force. The tip of the airway should be located into the upper esophageal opening. The cuff should be located against the laryngeal framework. The epiglottis should be held in place by the epiglottic rest. The gastric channel should open into the esophagus, and the incisors should be resting on the integral bite block.
so this
The iGel O2
also
should now
has
be
a
secured in
integrated
place with the airway support
bite
strap
block.
or taped down from
Coming to the maintenance of the LMS, we need to assess how easy it is to ventilate the patient, in the sense how the chest rise is there, ETCO2 can be connected, whether the ETCO2 curve is appropriate and it is ventilating correctly. These are clinical signs which we need to assess for continued maintenance of ventilation. And with less than 20 centimeter of pressure, there should not be any audible gas leak. If there is gas leak, we need to reposition the LMS. So the two indications include airway noise, that is gas leak, or there is an expiratory noise coming from the each positive pressure. That time you need to reposition the LMA, or there is a poor filling of the reservoir bag. That implies an impaired expiration. These are the two positions, two times where you need to reposition the LMA. Then once LMA is in place, it has a propensity to come out because of movements or patient is not fully sedated. So we need to secure the LMA with a tape or the maxilla, and we need to continuously monitor as we do for other cases. So once the indication for LMA is achieved, we can exchange the LMA to endotracheal tube or tracheostomy. Generally, endotracheal tube number 6 passes through through iGel number 4, or there are specialized tubes with the fast track LMA or intubating LMA where you can exchange the endotracheal tube. Another option is to go for definitive airway, including tracheostomy. We can also remove LMA once the sensorium improves. Then removal of LMA is also based on the depth of sedation. We can, in pediatrics, we use deeper sedations to avoid laryngospasm. In adults, generally, when spontaneous recovery and sedation comes, we can remove it in lighter sedation scales. Then once the LMA is over, generally the commercial indication is to use only once, single use. But many a times, many institutions practice reuse. So we can send it for sterilization and after watching for any physical damage from the use. So coming to the difficult airway algorithm, this is the difficult airway algorithm from the DAS Society of 2015, where the LMA fits for our clinical practice. So one is, as we said, its functional role includes in ACLS. Another is in anticipated or unanticipated difficult airway. When laryngoscopy has been done and if the patient is not been able to be successfully intubated, we declare it as a failed intubation, and second plan B is to maintain oxygenation and to use supraglottic airway device. So if we know how to insert a supraglottic airway disease device, then probably this will succeed, and we can stop. And once that is achieved, we can continue oxygenation or go with the further plan of action. If supraglottic airway device is also failed, we can go for final attempt of face mask ventilation and wake up the patient. If the patient still the ventilation is not been possible in this scenario, it is do not intubate, do not ventilate scenario. We have to go for front of neck access, which includes cricothyroidectomy or tracheostomy. So supraglottic airway device comes in plan B for elective intubations. For SLS, if you have the option for the SAD, you can use immediately. So this is about the LMA in difficult emergency airway.
Thank you, Dr. Chetan.
Thank you, sir.
It was a very good presentation. All the details have been filled in. So some people have this confusion like whether we have a third generation LMA. So
Yes.
what is this third generation LMA all about?
Actually, there are only two generations. First generation and second generation. Whatever third generation, it is just a commercial term. Introduction of gastric outlet in the LMA cuff, that defines the second generation. So whatever intubating LMA, fast track LMA, all those are second generation. Till now, we have not yet to come up with third generation LMA.
Dr. Chetan, can you show the picture that first generation, second generation? In one slide, all the LMAs were there.
Yes,
Can
sir.
you just differentiate like what you call first and what you call second?
Yeah, the main thing in the first generation was there was no introduction of gastric outlet, the tube. That was not there in the first generation. In second generation, the inventor, the LMA inventor introduced the gastric outlet tube in the cuff near the esophageal opening and commercialized as ProSeal LMA. So that is from there it started as second generation. Because it was patented, the other companies came up with different terms. They couldn't use the LMA as such, they used the other Supreme, other terms were used, iGel. So these are all the because of the patents.
Can you show the, in the picture?
Yes, sir.
Each one actually, which is the first one, which LMA?
Yes, sir. This is the classic LMA.
Okay.
This was the first generation. This is the second generation where you can notice the gastric tube at the esophageal opening, esophageal cuff. This is the ProSeal LMA. This also has a tongue bite. You can see it here. So these were made up of silicon. So which were recommended to be used for around 25 times by the inventor. So then with the single use, they came the little bit slightly more curved. This is a LMA Supreme. This is a second generation by Ambubag, where they increased the curve. So this helped in easier insertion compared to this. Then this is also another type of Supreme ProSeal. Then here these are the laryngeal tubes. In the laryngeal tube, this is like combi tube where one opening is sealing the esophageal opening. The another is sealing the pharyngeal opening where there is a conduit for trachea or the laryngeal inlet. So this is a laryngeal tube. Then this is a fast track LMA. And this is iGel, most commonly found. This is its carrier where it's a hard thing where we keep it so that it doesn't get deformed. This is its iGel carrier.
Okay. You told we can use LMA bridge to tracheostomy.
Yes, sir.
While doing tracheostomy, there is a risk of aspiration with the blood and entering into the trachea.
Yes, sir. Aspiration will risk is there. But because in the sense we are keeping for elective tracheostomy, generally we keep it as NPO. And in those, if we are using fiber optic as a bridge through the LMA, we can avoid intubation. And we can visualize.
The blood and secretions can enter into the trachea while operating, because the same area we are operating, bleeding happens.
Bleeding inside trachea, sir?
Yes.
That's always a possibility, sir. Even with the endotracheal tube also, we can't really secure, because it is like little bit above, and the tracheostomy insertion is little bit down the cuff from the endotracheal tube.
Okay. So bridge tracheostomy can we do elective as well as emergency?
Yes, sir. There are few case reports where they have used it, so that where the intubation response can all be avoided.
Any question from audience? Any question from audience?
Thank you, Dr. Chetan. And,
thank you, sir.
Thank you, Dr. Raghunath. It was a nice session. I would like to add one thing. Actually, in anesthesia, there is something called as a Bailey's maneuver. Okay, just before extubation, when the patient is sufficiently deep but breathing spontaneously, you remove the tube and put in a supraglottic airway device just to reduce the intubation response, extubation response, or hemodynamic variations happening during the extubation, or for smoother extubation. Sometimes patient they go for spasm and all. So when they're sufficiently deep but breathing, we just extubate the patient and insert an LMA. And when the patient is fully conscious, like is obeying commands, then only you try to remove the LMA. So the extubation or the removal of LMA will be smoother compared to the what they say is to the classical way of extubation. This is one modification of extubation which can be used in some patients where you are suspecting some if they're usually used in thyroid cases where they need to monitor for the recurrent laryngeal nerve spasms on. So that cases they are using. It is just a modification of one type of extubation. It's called as Bailey's maneuver. Okay. Thank you, Dr. Chetan. Thank you, Dr. Raghunath.
Thank you, sir. Thank you.
Thank you, Prashant, and thank you, Chetan. It was excellent presentation. Even though brief, whatever the information we want, we all got it from your presentation. I request all the, residents, senior resident, use LMA when there is a difficult airway. So LMA will be there in the crash cart, but somehow people are not using. So they are trying to repeated attempt of, intubation and harming patients. So we have to use LMA frequently when there is need is there. Okay. Thank you. Thank you, Chetan, once again.
Thank you, sir. Thanks for your organizers.
Thank you. Thank you, Remedy International, for giving this opportunity. Thank you.
Thank you, sir. Thank you, Dr.